Mrs. Kavya is a 25-year-old mother on the fourth day after a full-term, normal vaginal delivery. She has come to the sub-center with her newborn baby because of mild fever and difficulty with breastfeeding. We begin with a general examination of the mother. Her temperature is 37.9 degrees Celsius, pulse rate is 88 per minute, and blood pressure is 116 by 74 millimeters of mercury. She is conscious, comfortable, and clinically stable, although the mild fever requires observation and follow-up. Next, the abdomen is examined gently. There is mild uterine tenderness, but the uterus is appropriately involuted for the fourth postpartum day. There is no abnormal abdominal distension. These findings are largely reassuring, but the mother should be reviewed if the pain increases, fever worsens, or new symptoms develop. The lochia is then assessed. Lochia rubra is present, which is expected during the early postpartum period. It is not offensive, and there is no excessive bleeding. The mother should be advised to seek care immediately if the discharge becomes foul-smelling, bleeding becomes heavy, or she develops severe abdominal pain or high fever. The breast and milk assessment shows a cracked right nipple. There is no abscess, no localized hot swelling, and no clear evidence of mastitis. Milk expression is good, which indicates that milk is available. The difficulty in feeding is therefore more likely related to nipple trauma and poor attachment, rather than true insufficient milk production. The mother should receive reassurance, nipple care advice, and practical breastfeeding support. The baby is then examined. The newborn is alert, active, warm, and comfortable. The respiratory rate is 44 per minute, which is within the acceptable range for a newborn, and there is no chest indrawing, nasal flaring, or grunting. The general condition of the baby is reassuring. The baby's weight is 2.5 kilograms, compared with a birth weight of 2.6 kilograms. This small reduction is consistent with physiological weight loss during the first few days of life. The weight should be recorded and monitored, while continuing frequent and effective breastfeeding. Mild jaundice is visible over the face only. The baby remains alert and is feeding. This is likely to be physiological jaundice, but the mother should be advised to monitor the baby carefully. Urgent reassessment is required if the jaundice spreads to the chest, abdomen, arms, or legs, if feeding becomes poor, or if the baby becomes excessively sleepy. During breastfeeding observation, poor attachment is noted. The baby is taking mainly the nipple rather than a large portion of the areola, and the chin is away from the breast. This shallow latch can cause nipple cracks, pain, ineffective milk transfer, and the mother's feeling that she does not have enough milk. Positioning and attachment therefore need correction. The mother should be helped to sit comfortably, with the baby's head and body in one straight line, and the baby held close to her. The baby's nose should face the nipple. She should wait until the baby opens the mouth widely, and then bring the baby quickly to the breast. In a good attachment, more areola is visible above the baby's mouth. The lower lip is turned outward, the chin touches the breast, and sucking is slow and deep. The key message is to assess both mother and baby systematically, identify problems early, and provide supportive counseling rather than blame. Mrs. Kavya should be reassured that milk is present, and that improved attachment can make feeding more effective and comfortable. Exclusive breastfeeding should be encouraged, family support should be mobilized, and follow-up should be arranged. Case step content is for education only and does not replace clinical judgment or guidelines.